Hi everybody, I'm Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and today we will talk about ulcerative colitis. No, you're on Dr. Y channel? Well, I'm for you, I'm Dr. Y. So ulcerative colitis is a chronic inflammatory and ulcerative disease arising in the colonic mucosa, characterized most often by bloody diarrhea. Extraintestinal symptoms, particularly arthritis, may occur. Long-term risk of colon cancer is elevated compared to unaffected people. Diagnosed is by colonoscopy. Treatment is 5-aminosalicylic acid. Yeah.
5-aminosalicylic acid.
Corticosteroids, immunomodulators, biologics, antibiotics, and occasionally surgery. About pathophysiology of ulcerative colitis. Ulcerative colitis usually begins in the rectum. It may remain localized to the rectum. Ulcerative proctitis. Proctitis. Ulcerative proctitis, or extend proximally, sometimes involving the entire colon. Rarely it involves most of the large bowel at once. The inflammation caused by ulcerative colitis affects the mucosa and submucosa, and there is a sharp burden between normal and defective tissue. Only in severe disease is the muscularis involved. Early in the disease, the mucous membrane is erythematous, finally granular and friable. With loss of the normal vascular pattern, and often with scattered and hemorrhagic areas. Large mucosa ulcers with copious purulent exudate characterize severe disease. Islands of relatively normal or hyperplastic inflammatory mucosa, pseudopolyps, project above areas of ulcerated mucosa. Fistulas and abscesses do not occur. So toxic colitis or fulminant colitis occurs when transmural extension of ulceration results in localized ileus and peritonitis. So within hours to days, the colon loses muscular tone and begins to dilate, pathologically of course dilate. The terms toxic megacolon and toxic dilation are discouraged because the toxic inflammatory state and its complications can occur without megacolon, defined as transverse colon as more than 6 cm diameter, during an exacerbation. Toxic colitis is a medical emergency that usually occurs spontaneously in the course of very severe colitis, but it's sometimes precipitated by opioid or anticholinergic, antidiarrheal drugs. Colonic perforation may occur, which increases mortality significantly. Symptoms and signs of ulcerative colitis. Patients typically have attacks of bloody diarrhea of varied intensity and duration, interspersed with asymptotic intervals. Good term.
Interspersed
with asymptomatic intervals. Usually an attack begins insidiously,
insidiously,
which increases urgency to defecate, urgency to defecate, mild lower abdominal cramps, and blood and mucus in the stools. Some cases develop after an infection, for example, amoebiasis, bacillary dysentery. It's my neighbor, huh? It's awful person.
Bacillary dysentery.
Bacillary dysentery, okay. When ulceration is confined to the rectosigmoid, the stool may be normal or hard and dry, but rectal discharges or mucus loaded with red and white blood cells accompany or occur between bowel movements. Systemic symptoms are absent or mild. If ulceration extends proximately, stools become looser and the patient may have more than 10 bowel movements per day, often with severe cramps and distressing rectal tenesmus without respite at night. The stools may be watery or contain mucus and frequently consist almost entirely of blood and pus. Pus. Yeah, blood and pus. So the stools may be watery or contain mucus and frequently consist almost entirely of blood and pus. Toxic or fulminant colitis manifests initially with sudden violent diarrhea, fever to 40 degree of Celsius, abdominal pain, signs of peritonitis, for example, rebound tenderness, and profound toxemia. Toxemia. Okay. Systemic symptoms and signs more common with extensive ulcerative colitis include malaise, fever, anemia, anorexia, and weight loss. Extraintestinal manifestation of inflammatory bowel disease, IBD, particularly joint and skin complications, are most common when systemic symptoms are present. Why? Because actually ulcerative colitis and Crohn's disease are what? Are autoimmune disorders. So about diagnosis of ulcerative colitis: stool culture and microscopy to exclude infectious causes, sigmoidoscopy with biopsy. Initial presentation. Diagnosis of ulcerative colitis is suggested by typical symptoms and signs, particularly when accompanied by extraintestinal manifestation of history of previous similar attacks. Ulcerative colitis should be distinguished from Crohn's disease, but more importantly from other causes of acute colitis, for example, infection, in older patients, ischemia. In all patients, stool cultures for enteric pathogens should be done, and entamoeba histolytica should be excluded by examination of fresh stool specimens. When amoebiasis is suspected because of epidemiologic or travel history, serologic titers and biopsies serologic titers and biopsies should be done. History of prior antibiotic use or recent hospitalization should be prompt stool assay for Clostridioides difficile, formerly Clostridium difficile. Now we changed the name. Why, actually, I don't know.
Clostridioides difficile.
Clostridioides difficile. Clostridium difficile is not okay. So Clostridioides difficile, toxin. Yeah. Patients at risk should be tested for gonorrhea, Hesperovirus, HIV, chlamydia, and amoebiasis. Opportunistic infections, for example, cytomegalovirus, Mycobacterium avium intercellulare, or Kaposi sarcoma, must also be considered in immunosuppressed patients. In women using oral contraceptives, contraceptive-induced colitis is possible. It usually resolves spontaneously after hormone therapy is stopped. Stool testing for lactoferrin and fecal calpoproctin can be beneficial. Calprotectin. Okay, can be beneficial in differentiating IBD from functional diarrhea. IBD is what? Extraintestinal manifestations of inflammatory bowel disease. Okay.
Sigmoidoscopy.
Yeah.
Sigmoidoscopy
Should be done. It always visual confirmation of colitis and permits direct sampling of stool or mucus for culture and microscopic evaluation, as well as biopsy of affected areas. Although visual inspection and biopsies may be non-diagnostic because there is much overlap in appearance among different types of colitis, acute self-limited infectious colitis can usually be distinguished histologically from chronic idiopathic ulcerative colitis or Crohn's colitis. Severe peripheral disease, perianal disease, rectal sparing, absence of bleeding, and asymmetric of segmental involvement of the colon indicate Crohn's disease rather than ulcerative colitis. But actually, to understand situation, Crohn's disease and ulcerative colitis is like twice brother and sister. They're the same metabolic disorder. Colonoscopy is usually unnecessary initially, but should be done effectively in inflammation as extended proximal to the reach of the sigmoidoscope. Laboratory tests should be done to screen for anemia, hypoalbuminemia, electrolyte abnormalities. Liver tests should be done. Elevated alkaline phosphatase and gamma-glutamyl transpeptidase levels suggest possibly primary sclerosing cholangitis. Perinuclear antineutrophil cytoplasmic antibodies are relatively specific, 60 to 70% for ulcerative colitis. Antisaccharomyces cerevisiae antibodies are relatively specific for Crohn's disease. However, these tests do not reliably separate the two diseases and are not recommended for routine diagnosis. Other possible laboratory abnormalities include leukocytosis, thrombocytosis, and elevated acute phase reactants, for example, erythrocyte sedimentation rate, C-reactive protein. X-ray are not diagnostic but occasionally show abnormalities. Plain X-rays the abdomen may show mucosal edema, loss of haustration, and absence of formed stool in the diseased bowel. Barium enema shows barium enema shows similar changes, albeit more clearly, and may also, albeit more clearly, and may also show ulcerations, but the enema should be done during an acute presentation. A short and rigid colon with an atrophic or pseudopolypoid mucosa is often seen after several years of illness. X-ray findings of thumb printing and segmental distribution are more suggestive of intestinal ischemia or possibly Crohn's colitis rather than ulcerative colitis. Patients with known disease and the recurrence of typical symptoms should be examined. but extensive testing is not always required. Depending on duration and severity of symptoms, sigmoidoscopy or colonoscopy may be done and a complete blood count obtained. Cultures, ova and parasite examinations, and Clostridium difficile toxin assay should be done when there are atypical features to the relapse or when there is an exacerbation after prolonged remission, during a contagious outbreak, after antibiotic exposure, or whenever the clinician is suspicious. Patients require prompt hospitalization during severe flare-ups. Flare-ups.
Flare-ups.
Flat and upright abdominal X-rays should be taken. They may show megacolon or intraluminal gas accumulated over a long, continuous paralyzed segment of colon, a result of lost muscle tone. Colonoscopy and barium enema should be avoided because of the risk of perforation, but a careful sigmoidoscopy is typically advisable to assess severity and rule out infection. Complete blood count, platelet count, erythrocyte sedimentation rate, C-reactive protein, electrolytes, and albumin should be obtained. Prothrombin time, partial thromboplastin time, and blood type and cross-match are also indicated in case of severe bleeding. The patient must be watched closely for progressive peritonitis or perforation. Percussion of the liver is important because loss of hepatic dullness may be the first clinical sign of free perforation, especially in a patient whose peritoneal signs are suppressed by highly dosed corticosteroids. Abdominal X-rays are taken every 1 or 2 days to follow the course of colonic distension and to detect free or intramural air. Computer tomography is more sensitive in detecting extraluminal air or pericolic abscesses.
Pericolic abscess.
Avoid colonoscopy and barium enema in severe exacerbations of ulcerative colitis because of risk of perforation. My friends, don't forget that. Usually, ulcerative colitis is a chronic with repeated exacerbations and remissions in about 10% of patients. An initial attack becomes fulminant with massive hemorrhage, perforation, or sepsis and toxemia. Complete recovery after a single attack occurs in another 10%. Patients with localized proctitis have the best prognosis. Severe systemic manifestations, toxic complications, and malignant degeneration are unlikely, and late extension of the disease occurs in only about 20 to 30%. Surgery is rarely required, and life expectancy is normal. The symptoms, however, may prove stubborn and refractory. Moreover, because extensive ulcerative colitis may begin in the rectum and spread proximally, proctitis should not be considered localized until it has been observed for more than 6 months. Localized disease then later extends is often more severe and more refractory therapy. The risk of colon cancer is proportional to the duration of disease and amount of colon affected, but not necessary to the clinical severity of the attacks. Some studies suggest that sustained microscopic inflammation is a risk factor and that use of 5-aminosalicylic acid, 5-ASA, to control inflammation is protective. 5-ASA is protective. Why not to protect with microbiota of intestine, of bowel? No idea, actually. Why? They don't talk about that. Cancer begins to appear by 7 years from onset of illness in patients with extensive colitis and then develops in about 0.5 to 1% of patients each year thereafter. Thus, after 20 years of disease, about 7% to 10% of patients will have developed cancer, and about 30% after 35 years of disease. However, patients who have inflammatory bowel disease and primary sclerosing cholangitis are at higher risk of cancer from the time of colitis diagnosis. Regular colonoscopic surveillance, preferably during remission, is advised for patients with a disease duration more than 8 to 10 years, except for those with isolated proctitis, or where there is a concomitant primary sclerosing cholangitis. Right? Primary sclerosing cholangitis.
Primary sclerosing cholangitis.
Cholangitis, in which case surveillance colonoscopy should begin at the time of diagnosis. The guidelines suggest doing random biopsies taken every 10 centimeters throughout the colon when using high-definition white light colonoscopy, but doing only targeted biopsies of visible lesions when using chromoendoscopy to detect dysplasia. Definite dysplasia of any grade within an area affected by colitis is liable to progress to more advanced neoplasia and even cancer. After complete removal of endoscopically resectable polypoid or non-polypoid dysplastic lesions, colonoscopic surveillance is suggested rather than colectomy. Patients with dysplasia that is not visible endoscopically should probably be referred to a gastroenterologist with expertise in IBD surveillance using chromoendoscopy and/or high-definition colonoscopy to decide whether colectomy or continued colonoscopy surveillance should be done. The optimal frequency of colonoscopic surveillance has not been established, but some authorities recommend it every 2 years during the second decade of the disease and annually thereafter. Long-term survival after diagnosis of colitis-related cancer is about 50%, a figure comparable to that for colorectal cancer in the general population. Dietary treatment, of course. Dietary management and loperamide, except in acute severe attacks, for symptoms relief. 5-aminosalicylic acid, 5-ASA. Corticosteroids, 5-SA, how you to pronounce 5-ASA. Corticosteroids and other drugs depending on symptoms and severity. Antimetabolites or antimetabolites.
Αντιμεταβολητές.
No, in English, please.
Antimetabolites.
Antimetabolites. Biologic agents, Janus kinase inhibitor. Oh yeah, Janus kinase inhibitor.
Janus kinase
inhibitor or sphingosine 1-phosphate S1P receptor modulator. Huh?
Sphingosine 1-phosphate S1P receptor modulator.
Thank you very much. S1P receptor modulator.
Sphingosine 1-phosphate S1P receptor modulator.
Sometimes surgery. Details of specific drugs and dosage are discussed in American College of Gastroenterology, Guidelines for Management of Ulcerative Colitis in Adults. My friends, if you want to find this, no problem. Find American College of Gastroenterology 2019, Guidelines for Management of Ulcerative Colitis in Adults. But general management is what? Avoiding raw fruits and vegetables limits trauma to the inflamed colonic mucosa and may lessen symptoms. No, actually, very, 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 very questionable, this postulate. Anyway, a milk-free diet. Oh, actually, a milk-free diet is one of the most controversial advice. But anyway, it's noted. A milk-free diet may help but need not be continued if no benefit is noted. Very good that they note that in this guideline. Finally, it's not obvious. It's a consensus. Rather, this is a strict statistical data that a milk-free diet may help in ulcerative colitis or in Crohn's disease. It may be beneficial, maybe not benefit, but anyway, it's not to be continued if no benefit is noted. Thanks, authors. Absolutely agree with the authors. Loperamide is indicated for a relatively mild diarrhea. High oral doses may be required for more intense diarrhea. For example, 4 mg in the morning and 2 mg after each bowel movement. Antidiarrheal drugs must be used with extreme caution in severe cases because they may precipitate toxic dilation. Exactly. All patients with inflammatory bowel disease should be advised to take appropriate amounts of calcium and vitamin D. Routine health measurements, for example, immunizations, cancer screening should be emphasized. Patients with mild to moderate ulcerative proctitis or proctosigmoiditis that doesn't extend proximally beyond the sigmoid colon are treated with 5-ACA, mesalamine. Right? Mesalamine, but I'm not a mesalamine. Mesalamine by enema once a day or twice a day, depending on severity. Suppositories are effective for more distal disease and are usually preferred by patients. Yeah, really. Corticosteroid and budesonide. Budesonide enemas are slightly less effective. But should be used if 5-ASA mesalamine is unsuccessful or not tolerated. Once remission is achieved, dosage is slowly tapered to maintain levels. Or 5-ASA mesalamine drugs theoretically have some incremental benefit in lessening the probability of proximal spread of disease. Patients with inflammation proximal to the sigmoid colon or left-sided disease unresponsive to topical agents should receive an oral 5-ASA mesalamine formulation in addition to 5-ASA enemas. High-dose enemas, klizma. Yeah. High-dose corticosteroids are added for more severe symptoms after 1 to 2 weeks. The daily dose is reduced by about 5 to 10 mg each week. Immunomodulator therapy with azathioprine, azathioprine, or 6-mercaptopurine, mercaptopurine can be used in patients who are refractory to maximal dose of mesalamine and who and would otherwise need long-term corticosteroid therapy. Additionally, infliximab, adalimumab, golimumab, ustekinumab, and vedolizumab are beneficial in some patients. Vedolizumab.
Vedolizumab.
Okay, once a name, their names, please, once again. Lady.
Infliximab, adalimumab.
Oh my God. Are beneficial in some patients and may be considered for those refractory to immunomodulator. Thiopurine failure. Thiopurine failure. Thiopurine failure.
Thiopurine. Thiopurine failure.
Or corticosteroid therapy, as well as those who are corticosteroid dependent. Moreover, a combination of a immunomodulator and the anti-TFN therapy is sometimes helpful. Finally, in some patients who fail to respond to corticosteroids, immunosuppressants, or biologics, a trial of the Janus kinase inhibitor, tofacitinib, or trial of sphingosine 1-phosphate receptor modulator, ozanimod can be considered. Oh, my dear friends.
Sphingosine 1-phosphate receptor modulator ozanimod can be considered.
Ozanimod can be considered. Modulator. Okay, severe situations. Patients, severe disease of ulcerative colitis. Patients with more than 10 bloody bowel movements per day, tachycardia, high fever, or severe abdominal pain require hospitalization to receive high-dose intravenous corticosteroids. 5-ASA may be continued. Intravenous fluids and blood transfusion are given as needed for dehydration and anemia. The patient must be observed closely for development of toxic colitis. Parenteral hyperalimentation is sometimes used for nutritional support, but is not of no value as primary therapy. Patients who can tolerate food should eat. Patients who do not respond within 3 to 7 days should be considered for intravenous cyclosporine or infliximab or also for surgery. Patients who do not respond to a corticosteroid regimen are switched within a week.
Regimen.
Corticosteroid regimen are switched within a week or so to prednisone 60 mg oral once a day, which may be gradually reduced at home based on clinical response. Patients who are started on intravenous cyclosporine actually cyclosporine and respond to therapy are switched to oral cyclosporine and concomitant azathioprine or 6-mercaptopurine. Oral cyclosporine is patients who are started on 4-cyclosporine and respond to therapy are switched to oral cyclosporine and concomitant azathioprine or 6-mercaptopurine. Oral cyclosporine is continued for about 3 to 4 months, during which time corticosteroids are tapered and cyclosporine levels are closely monitored. So some clinicians recommended prophylaxis against pneumocystis jirovecii pneumonia during the interval of overlapping treatment with corticosteroids, cyclosporine, and antimetabolite. Tacrolimus and an immunosuppressant also used in transplant patients seems as effective as cyclosporine and may be considered for use in patients with severe or refractory ulcerative colitis who do not require hospitalization. The through blood levels should be kept between 10 to 19 nanogram per milliliter. Fulminant colitis. In fulminant or toxic colitis, if fulminant colitis is suspected, the patient should first stop all antidiarrheal drugs, take nothing by mouth and have inserted a long interstitial tube attached to intermittent suction. Receive aggressive intravenous fluid and electrolyte therapy within 0.9 sodium chloride and potassium chloride and blood as needed. Received high-dose intravenous corticosteroids or cyclosporine. Cyclosporine. Yeah. Receive antibiotics. For example, metronidazole or ciprofloxacin, etc. Perhaps receive infliximab. Having the patient roll over in bed from the supine to prone position every 2 to 3 hours help redistribute colonic gas and prevent progressive distension. Insertion of soft rectal tube may also be helpful, but must be done with extreme caution to avoid bowel perforation. Even if decompression of a dilated colon is achieved, the patient is not out of danger unless the underlying inflammatory process is controlled. Otherwise, colectomy will still be necessary. If intensive medical measures do not produce definite improvement with 24 to 48 hours, immediately surgery is required, or the patient may die of sepsis caused by bacterial translocation or even perforation. After effective treatment of a flare-up, corticosteroids are tapered based on a clinical response and then stopped because they are ineffective as maintenance. Patients should remain on 5-ASA drugs, oral or rectal, depending on location of disease, indefinitely, because stopping maintenance therapy often allows disease to relapse. Dosage intervals for rectal preparations may be gradually lengthened to every 2nd or 3rd day. There is a sample evidence that combination oral and rectal therapy is significantly more effective than either therapy alone. Either therapy alone. Oh. Either therapy alone. Patients who cannot be withdrawn from corticosteroids should be given thiopurines, thiopurines, or anti-TF drugs, Janus kinase inhibitor, tofacitinib, or a combination of thiopurine or methotrexate and anti-TF drugs. For more refractory cases, the anti-integrin vedolizumab as well as infliximab, adalimumab, golimumab, or ustekinumab can be used for both ulcerative colitis and Crohn's disease maintenance therapy. Finally, in some patients who fail to respond to corticosteroids, immunosuppressants, or biologics, tofacitinib or ozanimod can be tried as a maintenance therapy. Nearly 1/3 of patients with extensive ulcerative colitis ultimately require surgery. Total proctocolectomy is curative. Life expectancy is restored to normal, and the risk of colon cancer is significantly decreased. However, some studies report up to 25% of patients subsequently develop inflammation in the small bowel mucosa consistent with Crohn's disease. This may occur many years after surgery. That is why this is the same problem, same disease, my friends. After total proctocolectomy with ileal pouch anal anastomosis, IPAA, there remains a small risk of dysplasia or cancer in the rectal, cuff, and transition zone, and even in the ileal pouch. Ileal pouch.
Ileal pouch.
After proctocolectomy with ileostomy or EPAA, the quality of life is improved. However, new quality of life challenges are created. Emergency colectomy is indicated for massive hemorrhage, fulminating toxic colitis, or perforation. Subtotal colectomy within ileostomy and rectosigmoid closure, Hartmann procedure, or mucous fistula is usually the procedure of choice because most critically ill patients cannot tolerate more extensive surgery. The rectosigmoid stump may be electively removed later or may be used for ileonal anastomosis with a pouch. The intact rectal stump should not be allowed to remain indefinitely because of the risk of disease activation and malignant transformation. Elective surgery is indicated for cancer, symptomatic strictures, growth retardation in children, or most commonly, intractable chronic disease resulting in invalidism or corticosteroid dependence, invalidism. Severe colitis-related extraintestinal manifestation, for example, pyoderma gangrenosum,
Pyoderma gangrenosum.
Now better controlled by intensive medical therapies, are only rarely indications for surgery. The elective procedure of choice in patients with normal sphincter function is restorative proctocolectomy with ileonal anastomosis. This procedure creates a pelvic reservoir of pouch from distal ileum which is connected to the anus. The intact sphincter allows continually, typical with 4 to 9 bowel movements a day. Pouchitis.
Pouchitis.
Pouchitis is an inflammatory reaction occurring after restorative proctocolectomy with EPAA in about half of patients. The risk of pouchitis, appear to be higher in patients with primarily sclerosing cholangitis, in patients with perioperative extraintestinal manifestations, and possibly in patients with high preoperative serologic titers of perinuclear antineutrophilic antibodies and other inflammatory bowel disease biomarkers. Pouchitis is thought to be related to bacterial overgrowth and is treated with antibiotics, for example, quinolone. Probiotics may be protective. Most cases of pouchitis are readily controlled, by 5 to 10% prove refractory to all medical therapy and require conversion to a conventional Brooke ileostomy, the name of surgeon Brooke ileostomy. For a minority of patients who are older, who have well-established families and ill lifestyles, who have poor sphincter tone or cannot tolerate frequent bowel movements, or who are simply unable or unwilling to face the consequence of chronic pouchitis, the Brooke ileostomy remains the procedure of choice. Ileitis after EPAA and ileostomy is managed the same as other forms of IBD, inflammation bowel disease. Surgical procedures are rarely required. We talk about ileitis. Ileitis, okay. If any event, the physician and emotional burdens imposed by any form of colon resection must be recognized. And care should be taken to see that the patients received all the instructions and medical and psychological support it's necessary before and after surgery. So, my friends, about key points. So, ulcerative colitis begins in the rectum and may extend proximally in a contiguous fashion without intervening patches of normal bowel. Once again, this is an autoimmune disorder, my friends, as a Crohn's disease. Symptoms and intermittent episodes of abdominal cramping and bloody diarrhea. Complications include fulminant colitis, which may lead to perforation. Long-term, the risk of colon cancer is increased. Treat mild to moderate disease with 5 ulcer by rectum and for proximal disease by mouth. Treat extensive disease with high-dose corticosteroids, immunomodulator therapy, for example, azathioprine. Okay, azathioprine and 6-mercaptopurine. 6-mercaptopurine. Biologics, infliximab, vedolizumab, tofactinib, or ozanimod. Treat fulminant disease with high dose or ozanimod. Treat fulminant disease with high dose intravenous corticosteroids or cyclosporine and antibiotics. For example, metronidazole, ciprofloxacin, or infliximab. Colectomy may be required. About 1/3 of patients with extensive ulcerative colitis ultimately require surgery. Okay, my friends, that's largely enough concerning ulcerative colitis as a autoimmune disorder. So, my friends, that's enough. Thanks for your attention. Please don't forget to make your subscription to our channel. If you are in YouTube, just subscribe and put the ring on to be in touch with all news from Dr. Y, my name, my channel. And don't forget to make your donation. Their donates is highly appreciated. Without your donates, our channel will be closed. How to make your donates? My MasterCard is in description of this video, or just directly by YouTube possibilities. Goodbye.